Hello everybody, and welcome to our presentation of antibiotic overuse and resistance. My name is Catherine DeHarsh. I am a student at San Jose State University, and today we're going to be talking about what causes antibiotic overuse and resistance, as well as how this affects multi-drug-resistant tuberculosis and methicillin-resistant Staphylococcus aureus. So here we have a little infographic that shows some information about how to improve antibiotic use and combat resistance. It says that 70% of necessary prescriptions still need to improve drug selection, dose, and duration. What this means is that of the 70% of prescriptions that are necessarily prescribed, as in the patient needs the prescription, there is work to be done on what drug, the dose, and the duration, and 30% of prescriptions are unnecessary. This is a big contributor to the overuse of drugs. As we can see here, from 1989 to 2012, the number of prescriptions per person has increased dramatically. According to the World Health Organization, the WHO, 50% of medicine is prescribed, dispensed, or sold inappropriately, and 50% is taken inappropriately. Now, that's not to say 100% is wrong. That's not how that statistic works. But it means that there is work to be done both on the side of the doctor and the side of the patient. Some of the causes of antibiotic resistance listed here by the World Health Organization include the overprescription of antibiotics, or patients not finishing their treatments, or the overuse of antibiotics in livestock and fish farming, poor infection control in hospitals and clinics, lack of hygiene and poor sanitation, and lack of new antibiotics being developed. So a major factor affecting the overprescription of antibiotics is that some doctors state that they will prescribe an antibiotic for what is clearly a viral infection because, one, it makes the patient feel like they are doing something, and two, it can shorten the time of a consultation and get a patient in and out. This causes big problems because if we treat viral infections with antibiotics, this goes towards taking any bacteria that a person may be currently colonized with but are not causing illness and making them resistant to drugs in the future. Additionally, patients don't finish their treatments because they believe that they feel better and therefore they are better, when in fact they may still have bacteria that are not in large enough numbers to currently make them sick, but if they don't wipe them all out, they will rebound and cause sickness. The overuse of antibiotics in livestock and fish farming means that we are eating antibiotics that we do not need, which creates resistance in our bodies. So we're going to talk about Mycobacterium tuberculosis, which causes the disease tuberculosis. Typically, tuberculosis attacks the lung, but it can in fact attack any part of the body. It may be dormant, latent, and it is often fatal if untreated. Most people who are exposed to tuberculosis develop latent tuberculosis. It has no symptoms. They do not feel sick. They may be infected for a whole life without developing any symptoms. However, they may also get sick later in life if the immune system is weakened, especially in the case of HIV. A skin or blood test will show positive for tuberculosis, but a chest x-ray would be normal. And since they are asymptomatic, it is often overlooked. An active case of tuberculosis presents with a bad cough, chest pain, coughing up blood or sputum, weakness or fatigue, weight loss, loss of appetite, fever, chills, sweating, and night sweats. Both a skin and blood test and a chest x-ray will show positive for tuberculosis. Drug-resistant tuberculosis is tuberculosis that is resistant to some of its frontline drugs, in this case rifampicin and isoniazid. There are two main types of drug-resistant tuberculosis, three technically. There's isoniazid monoresistant, rifampicin monoresistant, which applies to both isoniazid susceptible and TB with unknown susceptibility to isoniazid. which is, however, treated as the third type, which is multi-drug resistant. This shows the percentages of patients with multi-drug resistant tuberculosis globally. So we can see here that a lot of the burden ends up over in the dark blue of like China, and it is less common in some of the more developed nations. The cases of multi-drug resistant tuberculosis has tripled from 50,000 in 2009 to 150,000 in 2017. In 2017, an estimated 558,000 newly developed cases of multi-drug resistant tuberculosis occurred, as well as 230,000 deaths. 3.6% of new patients and 17% of previously treated patients had multi-drug resistant tuberculosis. Kazakhstan, Kyrgyzstan, Moldova, and Ukraine have more than 25% of the new TB patients have multi-drug resistant strains, while in Myanmar, Nigeria, and South Africa, they have high incidence rates. 6.7% of multi-drug resistant tuberculosis patients have a strain that is also resistant to the fluoroquinolones and second-line injectable drugs such as amikacin, capreomycin, and kanamycin, which is referred to as extensively drug-resistant tuberculosis. In terms of treatment of drug-resistant tuberculosis, the graph here on the left shows that in clinical trials, treatment is about 79% effective, whereas in real-world treatment, it's only about 55% effective. And a lot of this has to do with the length of treatment. 9 to 24 months of treatment is typically required, and we'll get into that more in a minute. Detection of isoniazid monoresistant tuberculosis is crucial because treating it with first-line treatments results in treatment failure, relapse, and development of multi-drug resistant tuberculosis. For treatment of isoniazid monoresistant tuberculosis, it is recommended to treat with a later generation fluoroquinolone, such as levofloxacin or moxifloxacin, as well as rifampicin, pyrazinamide, and ethambutol. Treatment of rifampicin monoresistant tuberculosis has an unknown optimal treatment, and various drugs are prescribed. The WHO's classification of drugs for treating tuberculosis involves Group A, which are highly effective preferred choices, Group B, conditionally recommended when Group A is unavailable or untolerated, and Group C for when Groups A and B cannot be used. A treatment regimen should include 4 drugs from Groups A and B if possible, and is modified on the basis of available testing for further drug resistance. Short treatment is 9 to 11 months, and long treatment is 18 to 20 months. Short treatment is only available if the fluoroquinolones are tolerated, and 33% of multi-drug resistant tuberculosis is now resistant to the fluoroquinolones. Now we're going to switch gears to methicillin-resistant Staphylococcus aureus. Community-acquired refers to a condition that usually begins as skin infection and is often mistaken as a spider bite, with the same symptoms: swelling, redness, heat around the area, pus, etc. Healthcare-associated community onset frequently has comorbidities such as diabetes. Hospital-acquired MRSA, methicillin-resistant Staphylococcus aureus, may cause pneumonia, sepsis, surgical site infections, and even death. Hassoun, Linden, and Friedman in 2017 said in a 2-year period, 21% of persistent and 13% of intermittent carriers develop an invasive infection. About 1.3% of the general population is colonized but not infected. That means they carry MRSA, but it is not actively making them sick. 13 to 74% of Staphylococcus aureus infections are caused by MRSA, varying greatly by location. For treatment, rapid identification allows for more effective treatment. It lowers the mortality rate significantly. Treatment lasts about 14 days in uncomplicated cases and 4 to 6 weeks in complicated cases. A complicated case is indicated by things such as persistent fever at 72 hours, skin lesions indicative of systematic infection, positive blood test, presence of a prosthesis, neurologic complications, cardiologic complications, and others. Vancomycin or daptomycin is the preferred treatment. However, they are both contraindicated in the case of pneumonia, in which case linezolid or clindamycin is preferred. However, growing antibiotic resistance is a problem, as certain strains of MRSA are now resistant to drugs including vancomycin, daptomycin, and ceftaroline. Ceftaroline is also recommended in the case of pneumonia. In conclusion, methicillin-resistant Staphylococcus aureus has a 5 to 60% mortality rate if treated, but it depends on the patient population and the site of infection. Multidrug-resistant Mycobacterium tuberculosis has a 3% mortality rate if treated according to the WHO, and 45% if untreated. In both cases, researchers are hard at work on ways to increase the efficacy of current antibiotics, find new effective antibiotic treatments, and even search for treatments outside of antibiotics, such as gene therapy, which is modifying the genes of bacteria to make them susceptible, or in the case of MRSA, things such as blue light therapy.